Hi there. I haven't been able to introduce a speaker in a while, but I kind of butted in with the rest of the group and said I've got to introduce this man tonight. This is Dr. Robert Foster, and he is wonderful. He takes care of your hands and your wrists, and he does all that without undue pain. I know a lot of orthopedics that we come in to see, whether it's a knee or a hand or a wrist or whatever, and they go, does this hurt? And of course it hurts. But Dr. Foster is very kind about trying to find those areas that might hurt a little bit and might need some care. And he's just the best. But I'm going to go ahead and introduce him to you as far as his credentials and so forth. And he actually started out at UT and was getting his undergraduate degree in electrical engineering. Was it electrical or?
It was at first, but it was biomedical.
In electrical engineering, but it was too hard for him. So he changed to biomedical so that he would be able to get good enough grades to get into medical school. So he went to UT here in Austin, then to UTMB, Oregon Health Sciences, and University of Minnesota. Takes a lot of time to become an orthopedist who specializes in hands, because the hands, you know, they're very delicate. You've got these tiny little pieces of them. So it's probably one of the most difficult parts of orthopedics to get right. He's very passionate about his work. He has a background that makes him not only an expert physician, but a good person. He has 4 children and 2 grandchildren, 3 grandchildren now, that are spread out all over the United States, so he has to travel to see them. He's been voted by his peers Texas Monthly Super Doctors, Legacy Member Hall of Fame, Austin Monthly Top Doctors, and he also teaches at the Dell Medical School of Orthopedics for surgery. Now, when he and his wife recently, because their kids are all grown now and they're gone, and when they downsized, we've all done that. So what do you think was the hardest thing for him to leave behind when he downsized? Think of what?
His wife.
His wife? He took her
I didn't
with
think of that.
Yeah. Okay. What else has been really hard for you to leave behind? Come on. We all have it. Piano. No. But it's big like the piano. A 6-foot fish tank that he had had for 30 years.
20 years.
And it had all kinds of
Fish.
rare
Starfish. Anemones and crabs and shrimp and dories. We had Dory from Finding Nemo, the blue and yellow one, for 19 years. Dory, the same fish, was this big, and then a couple years later was this big. And when we moved, I had to take her back to the store because we didn't have a place for her. But
You
it
took
was our only
her.
fish with a name was Dory, because everybody else was just a fish.
Oh my God. And she's still, oh, I can't believe you
She's
took
not
that
anymore.
old
That
girl.
was, that was 3 years or 2.5 years ago.
Yeah.
But she was old for a fish.
Yeah, I've never expected a fish to live for 19 years. But please put your hands together and let's welcome Dr. Foster.
Thank you, Debbie, for that very fascinating story of me. And thanks for kind of roping me in to give a talk, because it's been good for me. It's helped me to organize some thoughts, and it's kind of fun to give a talk about a thing that maybe you don't have to spend much time researching, because these are the same things I do every day. And if it doesn't hurt too bad to see me, some of that is, as I teach the residents, the smallest needle and the strongest medicine. So whenever I have texts and they go, well, what kind of shot do you want to get? I want the skinniest, littlest needle and the strongest medicine. So my talk is about.
Can you move your microphone a little closer?
Yes, it looks a little foggy. Let's get it up and switch to this one. Hello. Okay, well, my talk is about things I do all the time and that lots of people have, and they sometimes wonder if they have them or they don't. But carpal tunnel syndrome, arthritis of the hands and wrists, and common hand conditions. So the things that are included today, but if you missed something and you want to know about it, feel free to stop me or ask me later. Questions are welcome at any time, because that's really what most of what I do is teach, and lots of people get better on their own if you teach them the right things. The things we talk about today are carpal tunnel syndrome, trigger finger, osteoarthritis, lumps and bumps and cysts and tumors, and Dupuytren's contracture or disease. So, what's carpal tunnel syndrome? Everybody says, oh, I think I have the carpal. Well, carpal, you have carpal bones. We all have carpal bones. The carpal tunnel is the U shape of bones that makes up the heel of your hand with a ligament across the top as the roof. I might want to put this in here or hold it for a second so that I can have two hands to point to things. So everybody here has a model to look at, because we all have at least one hand, and you probably wouldn't have come to this talk. So your carpal tunnel syndrome, your carpal tunnel, sometimes the tendons that travel through there are swollen and it squeezes the nerve. So it causes falling asleep of your fingers, pins and needles, or pain into the fingers. If you say it hurts in my wrist, I probably have carpal tunnel syndrome. No, carpal tunnel syndrome is that your fingers fall asleep when you're doing things and you gotta shake them and you gotta get some blood flow to them, and it just feels like they're alive with pins and needles. Ants. I cured some ants once on a lady who was in the mental hospital said they got ants on my fingers, and they brought me to her and I did carpal tunnel surgery and the ants went away because I didn't see the ants. But so at first, sometimes it wakes you up at night, or you start to go to sleep and it gets too much pins and needles to go to sleep. And so over time, it may be more and more numb until you can't button your own buttons because you can't feel where they are, and you have to look in the mirror to see if you've buttoned your button or not. So here is a carpal tunnel. This person's not doing very well with their hand like that, but so you can see the tendons are here in the middle. 9 tendons are in the carpal tunnel, 2 for each finger and 1 for the thumb. And a nerve, the median nerve, lives in the carpal tunnel with those tendons. So you may retain some water here and there, or you may rub your tendons by working hard, or you may cause some irritability, and the tendons may keep a little more fluid, which means it's tighter in there. If it's tight in there, then when you're awake and your hand is below your heart, you can pump blood flow to the nerve, and it's happy and you can feel things. But when you try to sleep, your heart takes a break, it doesn't pump so hard, so your blood pressure goes down. If your heart's not pumping hard enough to get the blood flow to the nerve, then the nerve says, hey, wait, somebody turned off my blood flow. And you get pins and needles in nighttime awakenings. So that would be for the fingers that are the thumb, the index, the middle, and half of the ring finger are supplied by that nerve. And so they can go out of order. If it doesn't get blood flow, it doesn't work right. It can wake you up at nighttime, or it happens when you drive, or you hold your hands up to do your hair, or so when you hold your hands up, your heart has to pump uphill, and it's harder to pump uphill, especially with the facing of the higher pressure, so that shows it more and more. Sometimes it happens when you talk on the phone or you kink your elbow. If you hold something for a long time, the tendons may be taut, and they kind of mush the nerve off to the side and keep it from having blood flow. It has
The sensation, it controls sensation for this part of your hand and this muscle. That's the thenar muscles. And if the thenar muscles don't have contact from your brain sending signals to the muscles, then the muscle doesn't know it's supposed to work, so it gets smaller. Here is, the yellow one is the median nerve, and here's the ligament that's the roof, and here are the tendons, 2 for each finger, 1 for the thumb. And here's the nerve branch to the muscle right there. So if this is too tight, some signals from the fingers to your brain are getting squeezed out and not carried back and forth, and the signals to the muscle are not getting to the muscle. What can we do? The most natural thing to do for it is to stretch the tendons through the tight spot and milk the swelling out of them. If you squeeze the tendons out, the pressure's down and there's room for blood flow for the nerve, and it can stay awake. So I tell people stretch the tendons, stretch the nerve in and out of the tight spot. Night splints, so a small carpal tunnel splint. I have some pictures of one here in a minute, but they help a little. Again, everything that could help is worth mentioning, because if it keeps you from having to have surgery, or it keeps you from having symptoms, then it's good. Anti-inflammatory medicines help a little, but not very much. This is a nerve glide stretch. So, leaving your neck are some nerves, and they go in the front of the arm, the front of the elbow. The one we're talking about is the median nerve, and this stretch is good for all of the way up and down. If you have a nerve problem in your neck, then stretching the nerve will pull it in and out of the tight spot and maybe wake it up. So the good thing of this is it doesn't hurt anyone, it has no cost, it has no risk, and it doesn't care where the nerve is compressed. So a nerve glide stretch, this is an effort to show it. If you lead with your fingers and you go this direction, at some point it feels tight. It's not who can go the farthest, it's just far enough to put some pull on the nerve. It's also called flossing your nerves. In other words, if you pull it back and forth, it can start to work a little better. So when it's away, when mine fall asleep, I wake my nerve up and go back to sleep. Doing it before bed is kind of a good idea, because then you can get it loosened up a little bit, get some blood flow supply, and then try to get through the night without having it wake you up. If it hurts when you're doing it, you're doing it too hard. This is a Google search of carpal tunnel splint. So there's lots of them, and they don't cost a whole lot. Here, this one's pretty small and out of the way. This one seems a little bigger than needed. That one seems a little bigger than needed. That's a little small, but again, its job is just to keep you from sleeping with your nerves kinked, so that you don't add to the squeeze of the nerve and have it have more trouble. So carpal tunnel splints, nerve glide stretches are for free and no harm, and so it's reasonable to try that anytime. If we're not sure if it's carpal tunnel or not, then sometimes we send for testing. Nerve conduction velocity and electromyography tests are done by neurologists and rehab medicine specialists. We have 2 rehab medicine specialists that do them at our clinic, but if they're behind or they're booked out a long time, there's neurologists that are happy to do them for us in the neighborhood. And they tell us, is your nerve carrying the signals as fast as it could, and where is it being squeezed, because there are other places it could be squeezed. So sometimes the symptoms aren't perfect or the exam isn't perfect to know, so a nerve test is helpful to see how severe it is or to make sure it's the real problem. The dreaded cortisone shot is okay to do in clinic. It takes 5 minutes. It's one of the least painful shots I give, and I do give some that hurt. And it goes right here where those tendons are. You can see my tendons moving if you're close enough. And so if you put medicine on those tendons, the steroid will take the swelling out of the tendons. And so if you want to get a nerve test or you want to test it physically by injecting it, those both help me to learn. So if I put a steroid shot in there and you say, oh, it's great for a month, then it sort of proved that we were on the right track. And if it wears off, you might still have to have carpal tunnel surgery. But sometimes it lasts and it doesn't need a surgery. Surgery is okay for carpal tunnel syndrome. It works well, and if part of what I like to do is the least invasive and the least misery-producing surgery. So there are variations, and different surgeons do it differently, but you can make a big incision from here to here. And in surgery training, they said they heal side to side, not end to end. So it doesn't matter if you need to make a big incision, then make one. But I don't like to make a big incision. I like to make a small incision. And then the smallest incision is a scope, where they poke a hole in and put the scope in and do it on TV. So no matter who does it or how, it's an outpatient surgery. You don't have to go in and stay in the hospital any. Some people are wide awake for it. Many of my patients, I say, do you want to be wide awake or do you want to be asleep? Because it goes probably 4/5 say, oh, I'd have that surgery, but I don't want to be put to sleep. And some say, I'd have that surgery, but I don't want to be awake. So I don't care which way it is. I'm good with either way. So everybody gets to pick. I've done thousands of them with people wide awake. And I have one person who said, you know, if I ever do my other side, I think I'll go to sleep. All the rest have said, oh, that wasn't so bad. And I like to play music in the operating room. When somebody's a little uncomfortable being awake, I like to play music to sort of put them what they want to hear. A side note, one of my most favorite stories of what kind of music would you like me to play during your surgery? Well, I had a lady who would be my mom's age, so getting up there, and she said, I don't want to have anesthesia. Okay, I'm fine with you not having anesthesia. And then I said, okay, well, you ready? And she was sort of just half paralyzed with fear, because I could tell, oh, she's pretty anxious. What kind of music would you like me to play for your surgery? She said, oh, I don't know, anything. Well, how about, let's see, if this was my mom, how about a little Glenn Miller? And she said, oh, well, that might be nice. And so I, and so it comes on, and she lifts, and I had already done the numbing of the fingers, the spot, and we draped and we started operating, and 4 or 5 Glenn Miller songs. We did her carpal tunnel and the trigger finger surgery, and she was starting to chat with the nurse, who was there's no anesthesiologist, and a few minutes later she started to tell me about where they would go to the dance halls, but by the time we're done, the drapes at the bottom are moving, and so she's dancing under the drapes. And so we finished and sewed up, and I said, okay, we're finished. She said, oh man, this is like the most fun thing I've done in a long time. So sometimes it matters and some people don't care, but she didn't think she cared until it kind of got to her spot. No matter who does it, it's an outpatient surgery, and the actual surgery takes about 10 minutes. Here's one of my partners. He called me on a Monday morning and said, hey, I've had carpal tunnel for a while, but I've been managing it with all the non-invasive things. But I did some yard work over the weekend, and my fingers are asleep and they're not waking up, so I think it's time. I put myself on your schedule for tomorrow. See, I figured on Tuesday I would do it, and I wouldn't do surgery until Thursday, so that gives me a whole 2 days to get better. And then on clinic, I'll have clinic on Wednesday. So he was wide awake, and we did his carpal tunnel. This is the I hit stop. That's not start. Back. See. So this is his incision. This is a retractor in the incision. There's his median nerve right there. And so we're cut down and we cut through. There's no muscles to cut. There's a ligament, and that ligament, if you cut it, the hand does the same stuff it used to do before. We have to be careful not to, I can touch the nerve. People go, oh, what was that? You shocked me. But I don't cut the nerve or touch the nerve very much. And so at the end, it doesn't particularly hurt to have the surgery. So people have it open on the other side the same way. So this is a mini open incision. Most surgeons don't put a cast or splint on afterward. I think it was tradition to do so in the 70s and 80s. And then we figured out if you cut something, it's going to try to scar down. And if you hold stuff still, it might scar to your tendons or nerves. And maybe your carpal tunnel will need to you'll have some scarring and you'll have to have something else done someday. So I tell people, make a tight fist, open your fingers as wide as they'll go, 10 pumps an hour to squeeze away the swelling and to keep the tendons and the nerve moving. It is okay to type and write and drive and click a mouse and eat with your hand immediately. People who drive themselves to the surgery center, go home, drive them home, sometimes with both hands in dressings. So it is okay to do light to moderate things immediately. I tell people to take off the dressing and get it wet in the shower on day 3. There are some surgeons who are day 2, some are leave it a week, but basically we don't want to hold it still. We want you to move it and use it. Using it hard isn't better, but stretching and squeezing away the swelling and using it for light to medium things. It's not important to me to impinge on your life. I don't want it to get dirty. So don't get it in the ocean or a hot tub or any place where bacteria might get in through the suture holes. The surgery is nearly always successful, but it has to be done for carpal tunnel syndrome to be successful. But if that's what the diagnosis is and it's correct, it's likely to solve the problem and usually permanent. Maybe 1 in 50 people, it might come back someday, but it could be 20 years later. Sometimes, lifestyle changes or some other disease that causes, like kidney failure can cause the swelling to come when it did before, and some forms of arthritis. If you haven't felt your fingers any in 6 to 9 months, then the pins and needles might go away, but it might take months for the nerve to fill itself back up. So if it takes 6 months of numbness before you have surgery, it might be 6 months before the sensation gets back out there. The thumb will be first to wake up because it's shorter, and the filling of the nerve fluid will fill back up to the shortest places first. Cubital. So carpal means wrist, of the wrist, and cubitus means of the elbow. So carpal tunnel syndrome, the median nerve is in the carpal tunnel and supplies these fingers. Cubital tunnel means the tunnel through your elbow. Your funny bone is your ulnar nerve. If you hit your funny bone, it shoots electricity to the little finger and half of the ring finger, because that's where the ulnar nerve supplies. It also supplies the muscles that put your fingers back and forth like that. So if you have cubital tunnel syndrome, then those fingers can go numb, especially if you kink it by sleeping under your pillow. And so it's a little bit of a bigger surgery for that, but the same nerve glide stretches are good for that. And not keeping it under your pillow when you sleep. If I wake up with those numb, I put my arm at my side. If it's all the time, then you can wrap a hand towel around here and put a piece of duct tape there, and then when you bend at night, your nerve says, oh good, not so far, I don't care about that, because if you flex far, your nerve smashes against the bone and that makes it get tingly in them too. Surgery for cubital tunnel might be just cut a little tight spot there, or sometimes the nerve moves back and forth, or there's arthritis of the elbow and we have to give it a new path. So it might be needing to be moved. That's all on cubital tunnel syndrome. It's just a very sort of nerve issues. Now we come to trigger finger. If the tendons are a little too swollen in your carpal tunnel, the nerve in there will let you know it's too tight in here, I don't have blood flow. But if your tendons themselves a little further out after they sort it out to their fingers, if they're swollen there, then they rub on the first pulley, a pulley being a ligament from a bone back to the same bone, so that the tendons glide through it like the eyelets on a fishing pole. If your tendons rub on the pulley number 1, annular, ring-shaped annular number 1, then they get swollen enough that the tendons bend your finger, and then it gets to the tight spot and your finger gets stuck. So fingers, especially happens in the morning, because you have all night with it to swell up, and then you have them bent and you wake up and you can't get it to unstick. That's called trigger finger. So triggering is the finger that gets stuck. It can come in groups. It can come with carpal tunnel syndrome because there's sort of variants on a theme. If your tendons are too swollen, the nerve might be choked. And if your tendons are too far where there's not a nerve, then they might get stuck. It might just be a little bit of a nuisance, but if it gets harder and harder to unstick, it can be painful. There are the tendons right here, and then there's these pulleys crossing them. There's a series of them, but the only one that can cause trouble is annular pulley number 1. And annular pulley number 2 is important, but never causes the problem. So we can treat a trigger finger by holding the tendons taut while we sleep or resting them. So this is a series of pulleys, of splints, and they're all basically to stop your finger from resting flexed so the tendons can't get stuck there. And that you can see they vary from $9 to $5 or whatever. So trigger finger splint, you get you this on Google. And medicine's a little bit of help with the anti-inflammatory, a steroid injection into where the tendons live. That would be here for that one, or here for that one, etc. And that's a 50 to 60% chance of solving it permanently. So it's literally worth a shot. Some people have had a shot or two and say, I don't want those anymore because I've already had 2 shots and they hurt. So you don't have to keep having shots, but that still leaves you with stretching the tendons or splinting them or having a surgery. So when someone says, I can't make a fist, well then I suspect their trigger finger got so bad that they can't bend it far enough to get stuck because it's stuck out there. And a shot might make them able to pull it through, and then it sticks, so it reveals itself as lurking as that. So trigger finger surgery means, just like carpal tunnel syndrome surgery, we cut the ligament that's the hindrance to making it work. And when people are awake for that one, we cut their pulley and I say, all right, make a fist, see if you can get it stuck again. And if it gets stuck, then there's more work to do, but it goes hundreds in a row without getting stuck again, and there's always a way to fix it when we get to that. But again, a small incision can be a local anesthesia. If you have a local anesthesia, you don't have a bill from an anesthesiologist. And it turns out they make just a little more than me on everything I do, so I'm not jealous, but if you don't need them, you don't have to have them. You don't need an IV, you don't have to go without food or water, you don't have to have a ride home if you have a local anesthesia. So I'm kind of for that, it's simpler. And most people like it that way. Some people are nervous, and that's okay at the beginning, but most times when we're finished, they say, oh, that wasn't so bad, that was fine. If I ever need this again, I'll do it like this. And again, you can use it for light to medium things right away. Here is a little movie of a trigger finger. So there, the middle finger, when you bend it down, it gets stuck. And sometimes it hurts and sometimes it doesn't hurt. And if it hurts enough, then again, stretching, massaging the fluid or swelling of the finger towards your heart, that's called retrograde massage. Or here is the surgery. There are 2 incisions here. This movie's about 20 years old and the technology wasn't very good when we made it. So it's a little blurry. But you can see I have a little incision there and I have a little hook, the little smooth retractor around the tendons, and I'm pulling them out. And some people want to look at them and some people want to not look at them, and that's fine either way. But then it's released and there's 2 trigger fingers side by side, and that's all there is to that. And that's about a, I don't know, 5 to 8 minute surgery. So, and again, no immobilization, and you can use it for most things, and the dressing stays till day 3 if I'm the one that did it. Now we come to arthritis. So a lot of people come and see me, I probably got arthritis. And some of them have tendon things or other things and stuff just hurts, and some of them have arthritis, but it doesn't always hurt to have arthritis. If your fingers are getting crooked or they're getting lumpy, they probably have arthritis. The kinds of arthritis, rheumatoid and psoriatic and lupus arthritis are inflammatory arthritises. And that means sort of, they happen in younger people whose body says, okay, there's some sort of assault on the joint, we're going to attack whatever's happening. And basically the lining of the joint proliferates and raises hell with the cartilage and the ligaments. So rheumatoid arthritis, complicated, and it has medicines that treat it. If you watch enough television, you've seen 100 ads per day on those medicines. They're generally effective. I do lots of rheumatoid arthritis stuff. That's my spot for teaching at Dell, is rheumatoid arthritis lecture for the residents. And that's because I'm old enough that they didn't have those medicines when I was in training in my first 7 or 10 years of work. There was rheumatoid arthritis kind of ran amok and people had to have surgeries. Now those medicines are pretty good, but as you know, they wouldn't be advertising if they were cheap. Osteoarthritis is by far the most common. It is the wear and tear arthritis. So osteoarthritis means the cartilage is worn. Did it have an injury? Did the nerves not make you protect it well? Or did your cartilage have some loss of strong binding to the bone and wear away? We don't know, but all of them are lumped together. Osteoarthritis is, there's no tests for it other than, oh, your x-rays show you have bone spurs, you have osteoarthritis. So it is the far most common. If your cartilage is worn, then the bone rubs on the bone, and that leads to friction and pain much of the time, but not always. So here is a finger that's crooked there and kind of lumpy that's missing the cartilage. So cartilage on an x-ray is invisible. So you can see these are smooth and they're not touching each other because there's cartilage in there. But here they're touching and not smooth. Here they're touching and not smooth. And down here, a very common place, extra whiteness from bone rubbing on bone, and space is lacking because the bones are touching with no cartilage to be the rubbery, slippery, gliding surface. So the base of the thumb is a common place to have arthritis, and that's because we're sort of built so we have it wear out. So here, if you pinch a thing with the tip of your thumb, this is pinching that, and the distance, so fingers, there's 4 fingers sharing the load and 1 thumb. The thumb has half the work, and it pivots down here, so its fulcrum is far from the job, so it multiplies the force. If you pinch 1 pound here, it's 10 pounds on the cartilage, and if you pinch 5 pounds here, it's 50 pounds on the cartilage. So it's a hard job for the cartilage to be the fulcrum from far away. And if it wears away, when you pinch hard, you rub the bones against each other similarly. So if you can grip a thing at the base, at the web space, it doesn't load the bone so hard. So that's costs nothing and has no risks. And so grab things here. If you get to choose between here and there, when you're really young and don't have any arthritis, then these don't make any difference. But later it can matter. And so just learning to use the web space and grip things when you can. If you can't use the web space, then holding that still while you're pinching, but not holding these things. So a brace for base of the thumb arthritis is one that holds that joint and none of the others, because if it blocks all the joints from moving, you'll take it off every time you ought to wear it because you can't do things with it blocking all your use of your thumb. Here's a couple of other over-the-counter things. There's a jar. Opening a jar is kind of the worst thing on your thumb, and that jar opener mounts under your cabinet and you just push into it and twist. It gives you leverage. Here's a pen that you don't have to pinch very hard. It just cradles on the finger, so this doesn't have to pinch it very hard, and it's shaped like that. Those are little things to get by, and it is okay to get by as long as they help enough. What else can we do? Well, osteoarthritis diet means fish with fatty acids like salmon and tuna, and colorful fruits that have vitamin C and vitamin K and antioxidants, and anti-inflammatory things like turmeric and garlic and onions and beans. And glucosamine and chondroitin sulfate are available. Osteobiflex makes a product that they advertise and is available at all the stores. And it is the building blocks of cartilage. Does it protect your cartilage? We're not sure we can prove it one way or the other, but it is okay to try, and it has no side effects. And if you took it for a month and go, oh, my hands have loosened up, or my knees feel better, or my back is better, then it's reasonable to continue. Heating the hand especially, because it's accessible that way, is a good way to let it become limbered up or stretch out the stiffness of it. Because when a joint is stiff, you run into its endpoints all the time, and that makes it sore. If you can stretch it and get it to move better, then it will run into its endpoints less often and hurt less. So heat will help it stretch. Ice, after you're hard on it or do something heavy or something repetitive and you think, oh, that's going to be bad, then ice keeps it from swelling and being sore. Compression controls its swelling. Strengthening by working on grip, and muscles that control you from walking into the endpoints and help cushion the landings and takeoffs. Here's a few things that are probably on Amazon or any other place, but this is just a compression glove that your fingers are free. It squeezes at night and it keeps them warm. This one plugs into a USB to be heated. This one goes in a microwave to be warmed up and then put on. So if your hands are warm, you can stretch them. This one has batteries in it and is heated with the same plugs in. And so heat helps you stretch, and if you can stretch, you might not need anything done or even have shots. So stretches and compression and heat are good. Here is a paraffin unit and wax. So when you heat up the wax, it's a great way to heat your hands by dunking them in hot wax. And you can see that is $90, but I'm sure there's cheaper ones. It doesn't have any moving parts, it's just a heating element. Here is sort of this lady has broken bones in her hand, but you can see it's shiny and swollen, and she can't bend it. And so this is similar to arthritis. If you bend slowly, you can squeeze the swelling, and if you get the swelling so I'm putting her wrist back and telling her, now bend your fingers until the skin is tight and the swelling is being squeezed. So she can't touch her palm, but this is an time lapse. But if we bend them and we squeeze the swelling, and if we take our time and squeeze all day long, I say bend until it feels tight, and it would hurt if you push harder, and then don't push harder. But if you keep at it and you keep squeezing the swelling, you can deflate the swelling, and then your hand can become movable. So she's bending farther and farther, and the creases in her palm have gotten deeper, and they turn pink because the blood flow comes rushing in when the swelling's mashed away. So that is, in 5 minutes, going from my hand is broken and I can't bend it to, oh, I can bend it. So I don't have one of arthritis for exactly the same thing, but this is a grip strengthener that's around $10, and if you take it in your hand and smash it about 30 times, you can see it's good for the muscles in your forearm. It's good for the muscles between the metacarpal bones in your hand. So if you squeeze it that way, or you can squeeze side to side on the same thing to make the muscles that stabilize your thumb. So for the arthritis there, if your muscles are stronger, it's like a splint, except it's not in the way any. And then some weights are good. And so you don't cause arthritis by exercise. You can be strong enough and healthy enough and have bone health if you exercise. Anti-inflammatory medicines can come as a rub-on topical. Voltaren gel got approved to be over-the-counter, so it's reasonable to try it. I don't know of any side effects from it over-the-counter topical rubbing onto wherever it's sore. Aspercreme is similar and was around a lot longer. And there are compounded medicines from a compounding pharmacy, but CBD oil is legal in Texas and everywhere. So if you put enough THC, the two components of marijuana are CBD, which has shown a lot of medical uses now, including in the Journal of Hand Surgery and the Journal of Bone and Joint Surgery, the most reputable things for all orthopedics. CBD as a treatment for arthritis of the thumb did just as well in a study that's published in a legitimate journal as any of the medicines, no matter how much they cost or how many side effects they would have for your stomach or your kidneys or your blood thinners. So pills, well, ibuprofen and Aleve are over-the-counter anti-inflammatories, and they fill the same niche as each other. And there are prescription ones. Celebrex and meloxicam are common ones to prescribe. And the only real difference in them is that the prescription ones can be one pill once a day, whereas ibuprofen is 4 times a day and Aleve is twice a day. And shots. So if a person has a painful arthritis of a joint, Sometimes they choose to have a steroid injection. There's really not cortisone in any cortisone shot at a doctor, at an orthopedic surgeon's office, maybe at an allergist's office. The cortisone might really be cortisone, but everywhere else, we want a medicine that won't wash away for 6 weeks. We want to put it in the joint, and we want it to stay there. And hydrocortisone washes away. So it makes it great for allergies because you can put it into a muscle or someplace, and it goes through your whole body, and then it's gone. So, but if you ask me for a cortisone shot, I know you mean these other steroids, and every other, all my partners, I'm going to give you a cortisone shot. Well, again, there are other steroids in there, and they stay longer, and they don't go through the rest of your body very much, so they don't have much in the way of side effects. People with diabetes, a steroid injection might make the sugars go up for a day, and if you're monitoring them, then you just take care of that. And then after a day, or maybe 2 days, it's back to normal, and the steroid is still in the joint, but it's not in the rest of your system. The shot also gives us the benefit of, if it's numb and we bend it, and it couldn't have bent before, when we numb it and bend it, then we can break free the scarring or whatever got it stuck, so that maybe you can keep it moving and you get a restart on its mobility. Hyaluronic acid, or Synvisc is one of the named ones. That's approved for knees by the government. And when it got approved, we thought, oh, then we're going to give this to everybody in all their joints that have arthritis. And then the government said, it's only been tested in knees. Why would we approve it for other joints? Because other joints don't know they're not a knee. They should. But because the government said it's approved for knees, it won't be covered by anybody's insurance. It'll be considered experimental for everywhere else. So no one's insurance covers it. And it's not proven to be that helpful everywhere else. I've injected it in some shoulders and some thumbs and some places. And generally it's done okay. But I don't have any studies that show that it fixed any problem. So the fact that it's not covered makes us just kind of a little bit give up on it. But if it works in your knees, it's reasonable to do. And so steroid injections, they don't cause trouble for your stomach or your kidneys like anti-inflammatories can, or for any tendency to have blood thinners. So you can't take anti-inflammatory pills if you're on a blood thinner. Other injections, whether it be something you saw advertised, which maybe should give you a little concern that maybe that's not a medically proven thing, but stem cells and platelet-rich plasma, I don't know of any study in any journal that says that they're helpful for the things we're talking about. Kinds of surgeries. Well, a debridement means you might take off spurs and make some room for some movement, or clean stuff out. Sometimes on the thumb, well, we'll come to that one. A fusion means grow two bones together so they don't move anymore. It can't hurt if it doesn't move and it's just one bone. There's no place to hurt. But it takes away your movement. It is good because it lasts and it doesn't wear out, and the joint replacement in the hand could wear out. Joint replacements. So in the hand, the only replacements that are completely approved are rubber hinges, and they're not very durable and they're not very likely to keep good motion. So we don't have a great joint replacement. If you know somebody that had a hip or a knee replacement, you know, well, they went back and they got a new one and they're good. There are some people that have trouble with hip and knee replacements, but a lot of people do great with them. But in the hand, it's just not as reliable. And this is an arthritis operation for the base of the thumb, which is reliable. So here's an x-ray where you, oh, I turned it off again. All right. There is loss of cartilage here. So this is the trapezium bone, and that's where you pinch, and this is where the cartilage wears out. Here is the trapezium bone absent, and here is a tendon. That tendon everybody has. So if I make an incision and take out the trapezium bone, the two bones can't rub on each other anymore. And then that other tendon attaches right at the base of the next metacarpal, and it can swing around and hold that in place. And that tends to last. The ones I did in the 1990s, I think, are still good. I expect them to last forever and to feel like they're normal again. So of all the joints that we work on, fusions never move anymore, and they're a little bit disappointing. And replacements might wear out and might have complexities of balancing them, but this one is reliable. Here is an x-ray of that bone missing, that bone and that bone fused together. And here's the healed incision there up to there. And it seems like if you fuse those bones, it turns out the base of the thumb, you can move pretty well at the base of the thumb where it used to have arthritis, and then the middle joint with the screw across it. Turns out people don't miss the movement of that one very much, so it feels pretty normal, and it has power and it lasts. So an operation I like to do, because I think in the future that patient is going to like me and be happy with it, and if I see him 10 years later or 20 years later, it's still going to be good, and they may even have forgotten about it. Here is a person who has a rubber joint replacement that has broken, and arthritis of the tip of the index finger, and arthritis at the base of there where this is rough and has worn through. So for me, oh, this is good. I will take out the broken one and I'll fuse that, but I'll need some bone graft, and I'm going to take out the trapezium, which can give itself to be the bone graft over here, and then I'll put a screw in there. So that is, this is a broken rubber hinge. This is the trapezium bone missing and put over there, and this is the screw holding that in place and that in place. And so here's a post-op visit, and that's going to be, I presume, she feels this is normal, and this doesn't really bend, but it's close enough to the tip that you don't miss it very much, and you don't miss the pain of it. And then this one had the joint replacement and had wandered off over this way. I didn't put that one in. I don't like the rubber ones, but mine are a little bit experimental. And so I think she won't have any pain with any of that in the future. Here is a little bit of an example of one I do. These are metal balls and plastic invisible because they're plastic sockets. And you can see that was kind of janky there and a little janky there and a little bit lost into there, and that's all lined up okay. But these are experimental, and people ought to try to not have them because there's a lot of things short of that that can still be all right. In the hand, if you have a bump, on to bumps. If you have a bump and it's getting bigger and it hurts, we should take it out and see what it is. If it's a ganglion cyst, then it's really just a joint lining cyst, and sometimes you can leave it alone or we can pop it. This is a ganglion here. The joint moves here. This is the lining of the joint or synovium. It has to have wrinkles, so you can stretch the wrinkles and accordion the wrinkles, and the lining cells make this fluid that is the lubricant. And so the lubricant fluid could maybe push one of the wrinkles open, and then it makes a pocket where the fluid gets trapped. And if the fluid fills it up, that's a ganglion cyst, which doesn't harm anybody. You can live with the ganglion as long as you like. They happen at the back of the wrist, at the front of the wrist. The tendons can have one. That's a little shiny, clear fluid, joint lining fluid. And then they can happen on the end of a thumb or a finger, where they make your fingernail look weird, or they look like a blister or a wart. And so any of those, you can leave them alone if they don't bother you. They don't bother me. And you can rest them. You can poke them to take some fluid out to see if taking the pressure off feels better and to prove it's a cyst. Or you can have them out. And if you have them out, you can move them right away, and that's okay. And they're relatively unlikely to come back with you taking them out. And they're a little more likely to come back than not if you poke them and drain them. Last topic is Dupuytren's contracture. It is an inherited process. People who have it, well, one of their parents likely had it, or two. It comes from people of Northern European descent, which includes me. I have it right here. Mine showed up at 57, and it hasn't progressed any, and I know I ought to stretch it because I don't want it to progress any. If you have a gene for it, Every child has a 50% chance of having the gene, but there are people who go their whole life and never realize they had it because it didn't bother them any. It is not a trigger finger that gets your finger stuck and unstuck and hurts. It is a band that thickens and tightens and pulls down if it wants to. It wants to sometimes if you break your wrist and you get a cast. Oh, look what that cast did. That doctor gave me a cast and look what the cast did. It's not the cast, it's the extra blood flow to heal the fracture that made the Dupuytren's wake up and progress. It can go a few months after a surgery or an injury where the Dupuytren's might tighten. Here, it also can show up in the soles of your feet or for males in their penis. And it can make it crooked, and you have commercials that feature the saying, bent carrot, call and get this. So, treatment for your Dupuytren's contracture of those places. Here is from a commercial. I took this picture. This is John Elway, the quarterback. And at the end of the commercial, he says, you should go to this website and check into that. See, I have Dupuytren's. Well, then why does he still have it if he had their treatment? So, so I took this from a picture of my TV. So this cord is what Dupuytren's looks like, and it's a band like that. And the treatments. If it doesn't bother you, you should still stretch it. If it bothers you and you can't put your hand in your pocket or put on a glove or put your hand flat, it would be reasonable to treat it. And treatments for it include, well, this cord, we can put numbing medicine here and stretch the cord taut and put a needle right beside it and then flick the needle back and forth and cut the cord, which is called percutaneous needle aponeurotomy. That, if you cut the cord, you can take it from here and sometimes get it to there in one clinic visit. So, collagenase, which is what John Elway's company wants to sell you, is an enzyme. And that enzyme, as collagenase, well, it breaks up collagen. If you inject that into the cord. So here's back to the PNA thing, I guess. Let's come back to the injection in a moment. But so, if I meet someone whose finger is stuck and they want me to do something today, I'll go get numbing medicine and an 18-gauge needle, and they'll sit in the same chair, and it'll take 15 minutes. And, well, it needs to be big. It's not for the shot. The shot to numb it is a 27-gauge needle. Once it's numb, then you can stretch it taut and cut the cord. And I have one here in a minute. So you can't do it if the cord is where nerves and tendons live. You can't do it blindly if you're once in a while you cut someone's nerve. That's not okay. So if they're awake and you think, is that a tendon or is that a cord? Well, if they're numb and I put the needle in there, I say, all right, move your finger. If my needle goes like that, oh, that's a tendon. I got to leave that alone if it's a tendon. So it's a little safer to do it wide awake than to have an anesthesia and a big deal made of it. Because if you're asleep, I can't tell if it's your nerve or your tendon or your cord. So often people go home with a Band-Aid, and some of them play golf the next day. And so it is, it's a thing that almost everybody leaves going, man, I had no idea I could leave with this thing unstuck. So if it goes from way stuck like this to way straight, sometimes there's not enough skin to do that, so that skin can have a tear. Doesn't hurt when it happens. Doesn't hurt that much later. No one has ever called me saying, hey, you should have given me some pain pills. So, and people call me. And so it can make a big gain, and sometimes it's forever and good. So here is a guy from 9 days ago. He's 81. He has this finger down there, that finger down there. These are pretty good, but his thumb is also stuck. You can see the cord right here to his thumb. And so there's his finger, and it doesn't straighten beyond that. Dupuytren's doesn't stop you from bending, it stops you from straightening. So here is, I injected there, and I poked him here, and there, and there, and there, and there, and there. But then I cut those cords, and there's his fingers all out there straight. All of those fingers go beyond flat up to there. You can see he did get a tear here. But in a week, that'll be healed. And my instructions to the people that I do that to is, make sure you stretch it out straight. We don't want it to heal because you went down there and made it easy to heal. We want to make the skin heal over that. And it will if you just give it a moment or a week. So needle aponeurotomy compared with collagenase injections. So that's an enzyme made by some bacteria who happens to break down collagen. Xiaflex is the drug that markets for that. And their commercials don't say there's Xiaflex or tell your doctor you need Xiaflex. They say, go to this free website of this nonprofit, factsonhand.org. Sounds like it's a nonprofit, it says .org, but it is going to refer you to doctors that use the enzyme medicine and not to Bob Foster. So it has the same constraints. If you inject an enzyme that eats collagen near a nerve or a tendon, it will eat the nerve or the tendon. So you can't do it where you can't be certain either. It does cost about $6,000 for one shot. So, and it takes at least 3 visits, because if you come and say, hey, this is stuck, can you unstick it? I can go to the cabinet and get a numbing medicine and unstick it, or I can apply for Xiaflex medicine and then call you when we got it. And then that visit, I can inject it into the cord. Can't give anesthesia because the anesthesia would swish it around too much and it could find nerves and tendons. And then the next day you have to come back again where I'll numb your finger and I'll try to tear the cord, which has been weakened by the Xiaflex. So the poking it with a needle is about 1/10 of the cost because needles don't cost anything. So both of them have a cost for the procedure, but the other one has 2 procedures and 3 visits at least. And so I prefer the poking it with the needle thing, and I do it a lot these days. And surgery is okay for Dupuytren's when it's too much, or they're behind, the cords are behind the nerves or behind the tendons, but it's not the first option. Again, if you say, well, my finger is stuck so far that I have to hold things with the finger stuck inside, sometimes we do surgery. I probably do 3 to 5 surgeries a month and 10 or more of the needle things a month, and I've given up the enzyme thing. So whatever it is, the gene remains there though, and it might show up someplace else. On your other hand, and it's not like fire ants where you chase out of one spot, it's going to show up another. So everywhere you can chase it out of, you can use your hand, and so Dupuytren's. And last is references and shameless plugs, and those on a handout. And this is our group, Texas Orthopedics. Today, Texas Orthopedics turns 40 years old. It was founded this day in 1986, and I joined in 1999. And we just opened a new office in Walsh Tarleton by Barton Creek Square, or Barton Creek Mall. And we have 6 other offices. I'm at the Quarry Lake office on 183 and Breaker. Well, there's a lot of doctors, and a lot of people don't want to travel to a doctor, so you got to go where there's people. And our doctors cover all of the trauma. The orthopedic surgeons at all the trauma centers have been our people for years. And this is, on your handout, that is the website for the American Society for Surgery of the Hand. So if it's on there, I agree with it. It is not controversial. It is as reliable. It is the place that, it is the end-all be-all for information on hands, which includes a patient segment, which is what that's a picture from. And it has all the stuff I've talked about and lots more. And this is the American Academy of Orthopedic Surgeons, and all of my partners are board-certified orthopedic surgeons or rheumatologists or rehab medicine doctors. And again, this is sort of the orthoinfo.org is from the Academy. That's our people who I think this is true. Oh, the Academy says otherwise. Oh, then maybe I'm wrong. So it's as reliable as it can get. This is called OptOrtho. We have joined with 6 other groups in Texas to form a supergroup big for contracting with insurance companies and buying our own health care insurance and the economies of scale without selling ourselves out to private equity, which turns out bad for medicine. So, but that's a website with all the stuff I say we have or you might like, you can see on optortho.com, and it links from our website. And that is all I got. So thank you for your time, and I'm happy to talk more as long as you like to have questions.
Are there questions?
Okay.
Yours first. My question
question is, what causes cramping in your hands? I get spasms bilaterally, and it's extremely painful. And the only way it'll go away is if I manually move them straight. And it doesn't last for very long. But I did have a fall flat on my back before I came here. And I'm thinking maybe it has something to do with my cervical spine.
Probably not cramps from your hands in your cervical spine, but if it's triggering, it can feel stuck or like a cramp, or your hands can be tired, meaning, if I do exercises and I walk a long way, or I'm dehydrated and then I go to bed, I wake up with a Charlie horse. So your hands, it is good to stretch those muscles that are crampy. It is good to work on power and endurance so they don't become tired. And then it may be a metabolic thing that's out of my area, but more likely it's not. More likely you stretch what tends to cramp at times, and you strengthen for power.
In the old days, we used to call it a ganglion cyst, and the treatment for that was a Bible.
Other books also can work.
Yes, they do. But that was the written description.
Well, I've heard it called a Bible cyst or a ganglion cyst. It is a ganglion cyst. If it's here, it's called a mucus cyst, which is still just a location for a ganglion. If it's here, sometimes the skin is so thin over it that it ruptures and you go, ooh, there's mucus on my finger. So a mucus cyst is a ganglion cyst. And a cyst on this over here is a retinacular cyst, but it's still a ganglion cyst. Or here. My dad had one here about the size of that. And I said, Dad, I can take that ganglion out if you want me to. And he said, why would I want that? So we did not. So we left it and it was fine.
But is that still the treatment for?
It really isn't the treatment, and it hasn't been since it can be ruptured. Sometimes so I can rupture it with a needle and numbing medicine first that will hurt less than whacking it. And if you whack it, it's likely to heal, and it still has the same shaped valve at the base, so it might come back. So it's pretty likely to come back if you do that, but you can do it again as many times as you want to. But I don't tell people they ought to do it. I would rather rupture it or take the fluid out of it, or try to cut it with the needle at the tip.
Could you please tell us about Raynaud's syndrome and if there are any remedies for that?
Raynaud's syndrome
Yes.
can be associated with lots of the autoimmune things, but also commonly not associated with anything. It is a tendency, especially if you're cold, for the blood vessels in your fingers to, if you climb Mount Everest, you're going to be so cold that your body says, I need to shift the blood flow, not waste my heat on the tips of my fingers. I need to keep the heart warm and the intestines and the brain. And so you can get frostbite because your body says, I lose heat here. So our fingers are supposed to have more blood flow or less blood flow depending on heat. So when you're cold, your blood vessels to your fingers shrink down, they contract. And they can do it too much so that you get white or blue fingers intermittently. That is Raynaud's phenomenon or Raynaud's syndrome. When it's associated with scleroderma, sometimes it's so bad that you get little sores on your fingers that can't heal because all the time your blood vessels are squeezing down. When people come with those sores, then the Raynaud's needs some treatment. The least aggressive thing to do is teach them that if you make a tight fist, and sometimes they're afraid because I got this thing, well, I should probably not do that. Well, no, you should bend and smash the blood out and let the new blood come. And so the more you pump out the congested old blood, the more the new blood will come and help it to warm. Wearing gloves or keeping them warm, or wearing a hat because you lose body temperature through your head. Those are ways to help. Medicines, especially Viagra and Cialis, are blood vessel opening medicines. But it doesn't need any treatment if it just turns blue here and there. But if there are sores or it's painful, then it's worth treating. And so the medicines that change the blood flow in your appendages, like Cialis does, then that is a real treatment for it. if none of that works and there's an ulcer and you're maybe gonna lose the tip of your finger, then I get Botox. So Botox paralyzes muscles. If you inject Botox at the base of the fingers, the muscles inside the blood vessels will become paralyzed and they won't be able to squeeze down. So for 6 months of Botox, you have better blood flow to your fingers. And so that's kind of a last ditch thing. And it's only been the last few years insurance companies have given up fighting over that because they hear Botox, they say, we're not paying for Botox. But Botox came from cerebral palsy research when children couldn't straighten their knees because they had so much spasticity or they had a finger over here. So they would inject Botox and paralyze those muscles and weaken them and stretch them back out so they'll quit walking on their toes or they'll quit having spasticity that they can't open their fingers. So Botox really has had medical uses before it had. The reason it works for wrinkles, it paralyzes the muscles that allow you to be able to make a wrinkle. So, but again, insurance companies don't want to pay for it, but now they've kind of given up because it has saved some fingers. And they're tired of hearing from us when I send them a packet of articles, then, oh, this is science, huh? So Botox is okay, kind of the last ditch thing, but stretching, warmth, and medicines. Okay.
One last thing.
Okay. Yeah.
As I understood you, you clip the cord. Why is that cord there to begin with if we can have it clipped and not need it?
Well, we all have a palmar fascia. The palmar fascia, if I hold my hand up, you can see I have a little bit of a cup there, or an arch of my hand. The palmar fascia is the arch of your hand, and the plantar fascia is the arch of your foot. So your hand has an arch. You don't have to put shoes on it, so you don't really pay attention to it having an arch, but the palmar fascia is there, and it was a mutation to cause the palmar fascia to kind of turn nuts and contract and have specialized cells that can thicken and tighten and pull down. And so if you clip it, it's not a tendon that you need. The arch of your hand might be different, but really it's more likely that you'll still have enough of that palmar fascia. I tend to take out almost all the palmar fascia when I do a Dupuytren surgery because almost all of it is thick and tight, and no one misses it because there's still the higher chance of them saying, oh, I have a flat hand. Well, that's okay to have a flat hand. So we all have one, but those of us with the gene for Dupuytren's, we have one that has a little bit lost control of itself and can't give up.
Well, that's going to be all the time we have for the questions that go on the recording, and if you have individual questions, maybe Dr. Foster will help you out.
Sure.
But thank you all so much for coming, and thank you for sharing all your wisdom with us. Appreciate it.